antibiotics in treating MRSA. Satish sir, please go ahead.
Good morning, all. Good morning, Mohan sir, Srinivas sir, Rani madam, David, all the seniors, and morning to all juniors. Today we are going to talk about MRSA covering antibiotics. What are those are available, and their advantages and disadvantages, and what are there in the pipeline. What are the newer antibiotics that are planning to come out of this experimental stage and getting into the market. So in that already for the last 1.5 years, 2 years, we are using this molecule like levonorepinephrine and some briefing about that molecule, comparison with all the other available anti-MRSA, like MRSA agents. So my talk will be in this order. Like initially, we should understand the burden of MRSA in India. Then what are the currently available antibiotics to tackle these infections? Then what is the new thing and the plus and minus of new available levonorepinephrine, and what is the evidence behind that, and how research has gone and finally came out this antibiotic is in the market. Then what is the safety profile? Stop sharing screen again and do it. See. Okay. So according to WHO organization, this is published in 2020. There is no specific research is being done, and there is no adequate antibiotics that are expected to come out in the market in the pipeline. And it's like one matter of concern because the MRSA prevalence is slowly going up, and whatever the available antibiotics to tackle these infections are relatively resistance is more for this. So we don't have a new antibiotic that is actually coming out of research, but whatever that is existing is not sufficient. So these are the two graphs, how the antibiotic resistance is developing as per this gram-negative bacilli and gram-positive cocci, both are compared. And in this gram-negative bacilli is very high number of antibiotics are available, but presently in the pipeline there are very limited. Similarly, for the gram-positives, they are very less. Overall, there is research is very lacking because maybe funding issue, and there is no specific research is actually taken by any of the pharma companies. So there are only 30 new chemical entities that are actually expected to come out, both covering gram-negative and gram-positive bacteria. So this is the one thing that is more looked towards this gram-positive coverages. So most of them is coming out of the phase 2 trials covering this surgical site infections, skin and soft tissue infections, CRBSS, and ventilator-associated pneumonias, UTIs. So this is gram-positive burden, microbiological profile of infections in the ICU. Like mostly in our ICUs, 69 to 70% is gram-negative infections, 16 to 20% is gram-positive infections, and mixed infections are around 16. But the MDR bugs, gram-negative is still in the side 20, and gram-positive is 16%. Gram-positive organisms usually they are causing surgical site infections, catheter-related bloodstream infections, diabetic foot infection, and catheter-associated intra-abdominal infections, bone and joint infections, febrile neutropenia, device-associated infections, sepsis. So in this, diabetic foot-related infections are high. Next to the surgical site and skin and soft tissue infections. So sepsis are coming up to 12.6%. Device associated is 41%. Febrile neutropenia, relatively less, they are 35%. So the site of infections can be community acquired, but rarely, it is relatively rare. Most of them are hospital acquired infections like ventilator associated pneumonia, catheter and bloodstream infections, skin and soft tissue infections, surgical site infections, sepsis of unknown origin, and febrile neutropenia. These are all the areas where we need to look into. There is a possibility we might get a MRSA in these patients. The current available MRSA, anti-MRSA agents, grossly speaking, we are all well acquainted with teicoplanin, vancomycin, clindamycin, linezolid, but relatively less used antibiotic is daptomycin. And tigecycline has a combination of both gram-positive and gram-negative, but it does not act on the Pseudomonas. So taking each into consideration, this is like nutshell slide for every antibiotic. Coming to the individual antibiotic, linezolid that is available, it is a brief note about this. It's it comes under the group of oxazolidine, and it's a bacteriostatic activity. It covers gram-positive cocci, methicillin-sensitive, methicillin-resistant Staphylococcus aureus, vancomycin-resistant enterococcal, Pezium, streptococcal pneumonia. It has an excellent oral and bioavailability. Both the ways it is good. Either it can be given IV or oral. There is no difference at all. Both the ways, the bioavailability is very good. Dosing is also same, both oral and IV. It has an inherently toxin neutralizing property. These are all the advantages to use linezolid, but we have to consider linezolid when it is used more than a week or 2 weeks. There is a possibility of bone marrow depression, thrombocytopenia. If it is given more than 2 weeks, and patient may have a peripheral or optic neuropathy. Lactic acidosis is one of the commonest complications which interferes with our sepsis management, because we go with the lactate, serial lactate estimations in the management of the sepsis resuscitation. So it interferes with that, and it is also concomitantly used some with other medications. Serotonin syndrome is one of the commonest side effects. So better to avoid using with other serotonin receptor inhibitors. It has a narrow spectrum of coverage, not approved in the MRSA bacteremia. Mostly it is used for the MRSA skin and soft tissue infections. Dosage is 600 milligrams twice daily, but advantage is no dose adjustment in the renal and hepatic impairment. But it comes as when IV preparation comes as 300 ml in a patient who is having a fluid overload status. This itself will take around 600 ml in 24 hours. Like, it adds to the positive fluid balance. So FDA has given indications when to use this. Vancomycin-resistant enterococcal Pezium associated with concurrent bacteremia. Nosocomial pneumonia, Staphylococcus aureus, Staphylococcus, both MSSA and MRSA. Complicated skin and soft tissue infections, including MSA and MRSA. Uncomplicated skin and soft tissue infections, and community acquired pneumonia because of MSSA and MRSA. But thing is, previously there used to be like a slight advantage in the literature says the linezolid penetration into the lung is good when compared to other MRSA, anti-MRSA agents like teicoplanin and vancomycin. But later it has been proven that there is no specific advantage of linezolid over other antibiotics. So we are not having this advantage as of now as per the literature. Coming to the other antibiotic is vancomycin, which is mostly used. It has a slow bacterial agent. It is a glycopeptide antibiotic. Its spectrum is also narrow. Variable tissue penetration. It's an IV preparation, but oral preparations are available. But I never seen that. But it's particularly used in the management of complicated C. difficile infections. The particularly therapy is guided by the trough levels. Trough level should be maintained around 15 to 20 micrograms per ml. And in inhibition, like resistance wise, if the MIC is more than 4, it is indicated if the bug is resistant to vancomycin. There is a dosing issue in this patient, in this antibiotic is used. It has to be adjusted to the not ideal body weight. It is to be adjusted to the actual body weight. Then it is initial dose loading is 20 to 30 milligrams per kg. At the rate of 10 to 15 milligrams per minute, not more than that. But if you give rapidly, there is particularly skin and some allergic reactions may happen. Oral dosing, C. difficile is 40 milligrams per kg per day in divided doses, 4 divided doses. So, as you all know, it is very known to have a nephrotoxicity when it is concurrently used along with the piperacillin to cover a gram-negative infection. There is a more chances of getting nephrotoxicity. Dose modification renal impairment is required. It releases histamine when it is given rapidly, causing a drug reactions, DRESS syndromes, drug reaction, esophagia, and systemic signs and symptoms. It is also a similar production of the Stevens-Johnson syndrome, but it does not involve the mucous membrane. Particularly when the patient is having HLA A332:01, there is an increased risk of estimate of DRESS syndrome up to 20%. And it also causes drug-induced thrombosis. All these gram-positive coverage antibiotics so far we studied, most of them are having drug-induced immune thrombocytopenia and neutropenia, bone marrow deficits. Next, coming to the teicoplanin, vancomycin is more studied in the US hospitals, and teicoplanin is more studied. It's not available in US, I believe. It is more in the UK. So it's a parental glycopeptide. Dosage is 6 milligrams per kg 12th hourly, followed by first 3 doses, followed by 6 milligrams per kg OD. It is also actually to be done along with the, as per the guidance of the trough levels, to be maintained at 20 micrograms per ml. But the setback is it takes longer period to have a therapeutic equilibrium, like therapeutic levels. 2 to 3 days it takes to reach a therapeutic level. Bone and joint infections, endocarditis dose is higher. It is 12 milligrams per kg. Trough levels to be maintained at 30 micrograms. Dose modification is required as per the teicoplanin. Usually, when the creatinine clearance is up to 60, same dose, less than 60. Frequency is Q48 hours, less than 10 Q72 hours, and it has to be like optimized to the dialysis frequency also. The other available is daptomycin. It's a novel lipopeptide. The one important finding of this is it is being inactivated by the pulmonary surfactant. So it is not used in the treatment of vapor respiratory infections. It has a skeletal muscle toxicity. So next is particularly heterogeneous vancomycin intermediary sensitive vancomycin intermediary sensitive bugs. It is to be like less susceptible. Narrow spectrum coverage similar to the rest of the gram-positive coverages. There is no oral formulation. Dosage is 8 to 12 milligrams per kg OD. It also causes immunothrombocytopenia, but specifically it has a property to cause myopathy, and there is elevated serum CPK levels. If the CPK levels is more than 5 times the baseline, better to stop this antibiotic. And there is one setback for this is it increases the PT-INR levels of the patient, but it is not the actual value. It is only an artifact. There is a reaction interacting with the reagents. So it seems to be there is a spuriously elevated PT-INR values. Clindamycin is a bacteriostatic, more for the community-acquired MRSA, not for the hospital-acquired MRSA. There is high resistance in Indian scenario. The side effect is it causes diarrhea, and it also causes Clostridium difficile enterocolitis. Inhibits the synthesis of toxins, and inherently toxin neutralizing property is one of the advantages of this antibiotic, and it is only through the inhibition of the protein synthesis by inhibiting the ribosomal activity. The last one available is tigecycline. It's a bacteriostatic activity, more of gram-negative coverage except Pseudomonas, but it has inherently very good gram-positive MRSA coverage. But availability is very low in the serum. It immediately dissipates into these tissues. It has a black box warning. One thing, like most of the patients, FDA has given a black box warning not to use this, particularly in the supradiaphragmatic infections. No oral formulation. Loading dose is required. There is studies between 100 milligrams loading dose followed by 50 milligrams BD versus 200 milligrams loading dose followed by 100 milligrams BD. Specifically, 200 milligrams loading dose followed by 100 BD has a good outcome when compared to the 100 with 50-50. Dose modification in severe hepatic impairment is required. there is no renal adjustment. But so here also there is one problem is it has some interference with the blood glucose measurements. Some formulations contain maltose, and maltose is recognized as glucose and shows the glucometer high glucose levels. But we tend to treat it with insulin, but patient will automatically land up into unrecognized hypoglycemia. But sugars will be normal, but patient will be having hypoglycemia. This is one thing we need to understand. So try to identify which formulation we are using, whether it is containing maltose or not. So having this background, we have five to six available antibiotics to treat MRSA, but most of them have lots of side effects and administration issues, formulation, some causing renal failure, bone marrow depression, dosage adjustments, and non-availability in the bloodstream. So these things raised an issue, and particularly we are looking for a newer antibiotic. Is there anything available to treat such infections? So this levonorofloxacin, these trials have been done both in India and USA. Most of them are Indian trials, but which is more relevant to our situations. There are two formulary available, Emroc IV and Emroc oral. That is levonorofloxacin IV and oral. Both are bioavailability is very good. Oral bioavailability is 90%, and it has a multi-spectrum coverage. Gram-positive pathogens, MRSA, vancomycin-resistant enterococcus, linezolid resistant drugs, macrolides, penicillin, all these bugs who are actually resistant, maybe this antibiotic is useful. Gram-negative pathogens, also very good activity against this, but FDA approval is not yet given for gram-negative infections. Still, so far we got an approval for gram-positive coverage only. It also covers atypicals like mycoplasma, chlamydia, legionella, and anaerobes, Clostridium and Streptococcus. Particularly in the against MRSA, it is very, very well studied. Even though there is a quinoline resistant bugs are there, levonorofloxacin, though it belongs to the quinoline group, it has a good susceptibility. This study is from the CMC Vellore, and there is one more study from the they specifically looked into 45 isolates which are confirmed by the Bengal bay clone. There's a specific bug. These particularly they studied and showed a very good susceptibility to this. So this is particularly they have studied vancomycin, linezolid, and levofloxacin comparisons. This levonorofloxacin MICs are very low when compared. The susceptibility is very high for these bugs. Particularly, it is useful in the MRSA infections. Particularly in the specifically in the biofilm when they looked into. This is the picture like scanning electron microscopy images at resolution of 50,000 times. Untreated biofilm will be like this. You can see the last trial when it is trough level is maintained around 8 micrograms per ml. Completely there is an eradication of the biofilm, which is compared to linezolid, it is 16 micrograms, clindamycin 32 micrograms, and daptomycin is 8 micrograms per ml. Both intracellular and extracellular activity will be there in the particularly lung epithelium, and it also has a very good effect in the even though patient is in metabolic acidosis, most of these other agents in an acidotic environment their efficacy will come down, but in patient with levonorofloxacin, whenever the pH is acidosis environment is there, still they are working in a better way. Like this is the table looking at pH 7 and pH 5.5. They looked into this levonorofloxacin versus moxifloxacin. In fact, in levonorofloxacin, the MIC levels are in the lower 0.25 also it is working, whereas in the moxifloxacin, the MIC value has gone creeped up from 4 to 16 to have a similar inhibitions. There is a 4 times lowering of the MICs. So that is the advantage of this newer antibiotic. It inhibits actually the cytokine release. This is the study. clinical studies, as I discussed, there are 18 studies so far we come across. The overall nutshell of this antibiotic absorption is 90% bioavailability is there, both oral and IV forms. High Cmax and short Tmax, and rapid and complete conversion to active drug when given orally. It's a oral given drug is a prodrug. Distribution is serum. It's a strongly protein bound 70 to 90%. So favorable to tissue and unbound plasma concentrations. Metabolism, hepatic metabolism is there through the two conjugative metabolisms. Lack of inhibition by cytochrome P450 inductions. Minimal drug-to-drug interactions. Excreted mostly through the urine and feces. But urinary excretion is relatively less. Then this is both IV and oral preparations. Similar graphs, both are equally like on the same lines. So there is no much difference between oral availability versus bioavailability versus IV. Intrapulmonary also, there is specifically there is a very good penetration into the lung tissues. This is all this new phase 3 trial has come. They compared linezolid with levonorofloxacin, and it is a non-inferior study. It is as good as Inflin, but it is not superior. Sorry, it is as good as linezolid, but not having any higher benefit over linezolid for the efficacy wise. But side effects wise, there are relatively less side effects when compared to linezolid. So this is the study they have done. Number of like levonorofloxacin IV versus IV and oral. Similarly, linezolid IV and oral to oral comparison, IV to IV comparison. Particularly infections in acute bacterial skin and soft tissue infections, patient with concurrent bacteremia and diabetic foot ulcer. So this is the overall efficacy wise. Levonorofloxacin is 91%, whereas linezolid in the first slide it is 87%. But and diabetic foot ulcer it is 91% and 76% comparatively. MRSA 95% and roughly 90% with linezolid. The adverse events are relatively less. So there is no nephrotoxicity reported, no hepatotoxicity reported, no thrombocytopenia reported, no QTc prolongation, which is there the problem with other quinolines, and tolerance is good. So the dosage is 800 milligrams IV 12th hourly, infusion over 90 minutes. Oral is 100 milligrams, 2 tablets, that is 1000 milligrams, that is 2 tablets, 2000 milligrams every 12th hourly. Contraindications, one, there is already some hypersensitivity to other quinolines. We are not supposed to use this medicine. Less than 18 years, there is no indication. And whenever there is patient is having a tendon, joint, or some, what is that called as ligamental issues, cartilage issues, we are not supposed to use this. Pregnancy and lactation also not included in the studies. No hepatic dose adjustment, no renal dose adjustment can be used safely in the geriatric patient. MROC versus other anti-MRSAs. This is comparison of majority of the available like levonorofloxacin, vancomycin, linezolid, and daptomycin compared to study. So coming to the conclusion, levonorofloxacin IV and its oral prodrug is levonorofloxacin. It's a broad spectrum benzoquinoline, a subclass of quinolines. Activity against MRSA, VRS, vancomycin resistant enterococcus, quinoline resistant strains, and activity against gram positives, gram negatives, atypical bacteria, anaerobes, but it is not given clearance by FDA. It is only given for an MRSA. Offers a simplified monotherapeutic advantage because it covers both gram positive and gram negative and anaerobes. Resistance is very less because it's not a substrate for nor a efflux pump, and DNA gyrase activity is less. So sodality, bactericidality is more with this. Dosage is 800 milligrams every 12th hourly, and oral is 1000 milligrams into 2 tablets, that 2000 milligrams 12th hourly, with or without food. Very good systemic availability, high attainment of intrapulmonary levels as in the epithelial lung fluid and alveolar macrophages. So better to use for all via like ventilatory associated pneumonias, hospital acquired pneumonias. Treatment of respiratory infection caused by extracellular intracellular pathogens. So it acts both extracellular and intracellular pathogens. Whenever there is acidotic environment, there is no difference of activity, and moreover, the activity is also improved with the acidotic environment. Activity against atypical bacteria and anaerobes, except B. fragilis. Its overall benefit is seen in skin and soft tissue infections, diabetic foot and foot, bone and joint infections. No adverse effects similar to other quinolines. Like we have a we can think of quinolines causes phototoxicity. Quinolines has prolonged QT interval. But in those compared to other quinolines, these side effects are not seen in this with this antibiotic, and there is a very good bioavailability both oral and IV forms. So better to smooth switch over from the parenteral therapy to oral therapy. So I think with this is the overall editorial that you can look into. I can send this in our group. The nutshell of whatever that is evidence available that is there in this article about this antibiotic. Thank you.